Well, welcome everyone. We're going to get started in a couple of minutes. So thank you for joining our webinar this afternoon on Journey of Strength, Native Trans Health, Access and Navigation. So we'll give people maybe about another minute or so and we'll formally get started. Okay, welcome everyone. Let's go ahead and get started with our webinar series. Thank you for joining us for our fourth webinar with the National Native HIV Network. This webinar is going to be focused on transgender health and is entitled The Journey of Strength, Native Trans Health, Access and Navigation. We're very fortunate enough today to have individuals and presenters who will share their expertise and knowledge as professionals and providers, and then also some personal experiences as individuals who identify from this population in this community. So welcome everyone. We also have, and my name is Elton Noswood. I am of the Navajo Nation. I'm currently residing in Denver, Colorado. I am the co-coordinator of the National Native HIV Network. And we also have Mr. Kurt Begay, who I'll go ahead and give a brief introduction as well as some housekeeping updates.
Thank you, Elton. Again, as Elton had mentioned, my name is Kurt Begay. I am the Capacity Building Specialist with the Albuquerque Area Indian Health Board, also co-coordinator of the National Native HIV Network. So just real quickly, some general overall housekeeping items for all of us. I just want to let you know that this webinar is being recorded. So for those of you, this will be available for viewing after the session. So we'll definitely email out a link for the recording, but it will also be posted onto our Facebook page as well as our YouTube page. So just keep a eye out for that email as well. So definitely we want this to be very interactive, and we'd love to see where folks are coming from. So if you would go into the chat room and just type in, introduce who you are by your name, your tribal affiliation, and which agency you represent, that would be great, just so that our presenters can see where folks are coming from, and also give us as facilitators and coordinators a general idea as to where people are coming from. And we definitely encourage questions. So definitely you will see in the, probably depending on how you're viewing this, if it's on the top menu bar or maybe on the bottom menu bar, there will be a Q&A section. So please just type in all of your questions there, and our presenters will take time to, at the end of their sessions, to answer those questions. And also Elton and myself will be monitoring those. So we will definitely have a Q&A section at the end of the webinar. And at the conclusion of this webinar, you will then be directed to an evaluation. So please, we definitely would love to have you all complete the evaluation, because that helps us as we continue to plan future webinar sessions, but also it's a good idea to then provide information back to our presenters as far as your thoughts and comments about the session and the information that they are sharing today. So with that, I turn it back over to Elton.
And thank you, Kurt, for providing that information. And just to let everyone know, also in the chat, if you want to utilize the panelists and attendees section, so everyone will see where you're from. If you just select panelists, then we're the only ones that are able to see you. So just letting everyone know that. And then also, as Kurt said, the question and answer section will be for our panelists. And we've agreed to have those question and answers being answered at the end of the presentation. So thank you for that. So our first presentation, we have these 4 wonderful presenters. We have Itai Jeffries, Dr. Jennie Wei, Mattee Jim, and Cathy Taffy Kapua. And the order we will be presenting is as you see it on the screen. So our first presenter is Itai Jeffries, who is a Two-Spirit educator and qualitative researcher and equity consultant. They are a partner of the Baywa Emergent Equity Incorporated, a racial equity and organizational development firm based in Chapter Hill, North Carolina. Itai currently leads the PATHS Remembered program at the Northwest Portland Area Indian Health Board, a Two-Spirit LGBTQ+ health equity initiative. And I'm going to go ahead and let Itai introduce themselves, as I don't want to mispronounce their tribal affiliation as well. But I also met Itai many years ago while doing some health work with the CDC while they were living on the East Coast, and feel very honored that we have them here to present with us today.
Thank you so much, Elton, and I'm really grateful to have been invited. Thank you, Kurt and Elton, for putting this together, and I'm grateful to have been invited and to have met you so many years ago, Elton. So I'm Itai Jeffries. I come from the Yesa people. We're also known as the Okinichi tribe of North Carolina. I'm born of the white people and a child of our Bear Clan. And I identify myself as Two-Spirit, also gender non-binary, and I use English pronouns, they, them. And the reason I say English pronouns is because in my language, we did not have gender pronouns prior to colonization. And so the way I want to start this today is I'm going to be talking a little bit about the work we're currently doing at the Northwest Portland Area Indian Health Board. And I want to say first, though, that what brings us here to this journey of strength, which is really a title that all of us presenters kind of came up with in a mind meld when we were planning for this. And it was a really exciting title because we were all talking together about what does it mean? How do we talk about the journeys that we go through and that folks go through to access healthcare? And it is a journey just like all the rest of our journeys, a journey of not just survival really, but strength. And I want to lift up the ancestors the Two-Spirit ancestors especially, and all of our indigenous ancestors who came before on these lands, because our continued existence, our ability to stand here and speak today is really proof of that strength, that journey of strength is one that has gone on forever and continues today in the ways that it can. And so that's what resiliency looks like for me. Every day when I approach doing this work, or I even get myself out of bed, I think a lot about the fact that we're here because of the prayers that they made for us, those who would come after us. And I'm really grateful for them. And we know that, the terrors that we faced in our communities, but specifically Two-Spirit people, in the way that we have been targeted. And in the same way that hate crimes are supposed to send a message to the person who is victimized. When we were targeted, it was to communicate a message about what acceptable gender expression would look like in Western culture, and that we would not be part of that. And so we're here, and I'm very grateful again to be here. So I also look to, right now we're doing a lot of work with the Northwest Portland Area Health Board that involves youth, and youth are engaging with us in webinars like this, in platforms like IG, and through a youth advisory group that we're putting together. And I think about even the ways that I describe myself now. Back when I met Elton just like 10 or so years ago, I didn't have that language. And the ways that our youth and young people are picking up that journey and moving that journey in ways that I didn't even see possible, giving me myself a different way to understand who I am in relationship with myself, my community, and my peers today. And so I'm grateful for them as well, who are changing and evolving and creating space, I think, for all the ways that we show up, and how that has also impacted our journeys in healthcare and what we even think is possible. Right? I'm going to circle back to my own story for just a moment before I really say what it is that we're doing at the health board right now, because you know, back when I sort of came out the first time of the different coming outs, the only language that I had is that the way I could describe myself would be gay, right? Gender non-binary, or even locating something at the site of gender was not something I had the language for. And so, you know, as that kind of evolved, I started to be able to think about myself differently. And there are multiple journeys and multiple times that I re-entered the circle, or that I reimagined the circle for myself. But one of the most profound was at a conversation with the Okanichi traditional health circle back home that I was invited to sit at, which was a group of women. And they said to me, I had asked, like, they were making some decisions at that table, and I'd been invited to be a part of that table to make decisions for our people's health. And I said, okay, well, this is a women's group. It looks like, do I need to, when you make a decision, do I need to remove myself or leave? And one of the elders there, she said, no, you're two-spirit, you belong here, right? And so this re-entering of the circle that I'd done all these different ways and kept defining myself differently over time, I realized that the circle really didn't change, right? We just all didn't have access to understanding what it was. And I'm really grateful to my community for sharing that with me. And when we recently renamed our program, our Two-Spirit program at the Northwest Portland Area Indian Health Board, we had been thinking about the fact that 2S LGBTQ program was not sufficient. We wanted to have a name to describe the work that we do that allows people to think about, you know, why we're here and what it is that we think we're doing as an agency. And together with our trans health work group and some of the folks that are on our team at the health board, we contemplated this and we received feedback. And what we landed on was the Paths Remembered project. And the reason that is just like what I said earlier. We know that our ancestors already created this space for us, and we're breathing life back into that space. Young people are a part of it, our elders are a part of it, but we're breathing life into it. And for every decision that we make to create that space for ourselves and our community and our healthcare when we're interacting with our providers, is to do just that, to restore that space, right? So what we did starting about 6 months ago was that we did a survey that went out nationally. And the survey was intended to capture anybody who identified as indigiqueer, the whole spectrum of LGBTQ, two-spirit, and transgender specifically. And what we expected really was to get probably, you know, 10, 15, 20% of the respondents we thought would be gender diverse or not cisgender. What we actually received, though, was of our respondents, almost half were actually gender diverse. And 70% of them identified as two-spirit. When we think about that in comparison to some of the earlier data that had happened, there's a huge shift that's happening. People taking back different ways of identifying themselves, and also more people really locating gender as a place where our identities as Indigenous people who have this whole host of indigiqueer experiences is important and might be different from the mainstream LGBT community as well. So some of the findings from that data I want to speak to just broadly. And the reason I'm going to speak to broadly is that we have a community session on the 27th so that we can present the data to our 2S community, to our indigenous relatives, and ask folks how it is they want the data to be used. So I'm going to be very conservative in the way that I share the data today because we haven't gotten all of that feedback. But as you might imagine, because you've probably seen data on LGBT people in general, but Two-Spirit and Indigenous people more broadly, what we saw was quite a few breathtaking disparities, right? The problem with a lot of data that exists, especially that data that's not collected by Indigenous people for Indigenous people, is that the research stops there. They describe our disparities. They describe the ways in which our community might be experiencing challenges or difficulties, or the community would feel broken if you read the results of a lot of previous research, right? So we were really intent on not stopping the narrative there. So yes, we found some very intense things. One finding would be that the vast majority, I would say nearing total majority of our the people who responded to the survey were experiencing some level of suicidality, right? Or suicidal ideation. That's a hard thing to talk about. So we want to receive some information from our community about how to present the specific numbers when it comes to that. But one of the other things that we found was that regardless of all the challenges that were named when our gender diverse folks talked about their access to healthcare, all the challenges like financial challenges, being afraid to talk to providers about gender, being afraid of being outed, right? Those things that we expect. Some of the other things like fear that the providers won't have cultural competence in any way or won't understand Indigenous practices or traditions, right? Each of these things, despite that, a high number of folks were trying in their own way to access different types of healthcare services, right? So people were overcoming a lot of those barriers. What was also interesting is we asked folks about how they value their gender identity, sexual orientation identity, but also their Indigenous identity and the history of their people or their land. And what we find is very strong valuation of gender identity, very strong evaluation of or self-valuation of sexual orientation, but low in comparison to the way that we think about our indigeneity. So people's the way they value that was like 99 or 100% that everybody valued their Indigenous identity. So when I hear that, and I think about the providers that I've interacted with, that sends a real strong message to like what we need when we're accessing healthcare and when we're having conversations with providers. And that is that who we are as a total person, not just who we are as a person who's asking for HRT or as a person who's asking for a specific procedure, who we are as a total person is going to be really important just to be seen. Not that that person has to know everything about who we are, know everything about our tribe or what practices we come from, or even what language we might use to describe ourselves in our original tongue. But the fact that who we are as an Indigenous person, the lands that we come from, the practices that we believe in, and the ways that we might see our health is going to be absolutely essential into any care that we might receive, be it behavioral health or even our physical health that we might be going through as well. So that's the way that I think about what we have found. And it's really beautiful to find that, because that actually demonstrates not only this idea that the title conveys today for this webinar, this journey of strength, that we're coming with very strong identities, right? And that we have a good self-concept. We need help to be able to access the things that help us to feel more comfortable in our body or in our society, right? Moving around in the social spaces that we're in. But we're not coming as broken people asking to be fixed. It's not just that either, right? It's that we're whole and strong people. So the data really helps me to think about that and gives me something to talk about. And so I'm really excited. I hope that those of you who are indigiqueer can look us up on our IG at 2SLGBTQ and look at the information about that community discussion about the data, because we would absolutely love to have your input, and it's on January 27th. So make sure you check that out. And I want to just real quick before I turn it over, I want to save a couple minutes for my teachers in this, which are Cathy and Mattee here. I want to hear from them because to circle it back to my experience, I am at the very early stages of pursuing gender affirming care for myself. So I've been able to hold space for other people, to visit people when they've had operations procedures or first started HRT and was experiencing different changes. And so since I'm at the very beginning, they are my teachers and I'm going to be listening to them and may call on them for their advice or support too. But in doing so, like, it just gives me so much strength myself to hear stories from other people. I've done like everybody does. I do like thousands of Google searches and I'm reading all these things and reading articles and like YouTube videos or whatever comes up, right? But nothing is as helpful to me as talking to somebody who went through the exact same procedure that I am trying to embark on, right? Because I want to know, like, you know, was it scary? Was your doctor nice? Can I get your doctor if they were nice? Like, you know, am I not going to be able to talk for 2 weeks? Or, you know, what's going to happen, right? I want the real. And it's so helpful to be able to have people who are strong enough and who are brave enough to speak in communities that are not always accepting of who we are, and to be able to say something to everyone else about that journey, what it looks like to access care and to stand up for yourself as an indigenous queer person. So also my hands out to the two of you today for sharing that with folks as well. So I'm going to wrap it up there a couple minutes early and save more time for them. Thank you.
Thank you, Itai, for that presentation. And I'm really excited about these conversations because it's going to be a varying spectrum of individuals who identify as a trans individual. So thank you very much, and for the work that you're doing around data and research with the Northwest Portland Area Indian Health Board, which is also very important for this population as well, you know, in terms of us as Native and Indigenous people doing research for our own communities that we identify with. So I really appreciate that. And encourage everyone to go to the website, you know, to see more about what they're doing and providing in terms of services as well. So we're very honored today to be able to have a clinician's perspective on working with trans clients and, you know, clinical care in that way. Dr. Jennie Wei has agreed to present with us and is attending, knowing a very busy schedule, you know, at the clinic that she serves at during this time of COVID. So we're very honored to have Dr. Wei with us. Dr. Wei has been working as an internal medicine physician at Gallup Indian Medical Center since 2012, spending half of her clinical time as a hospitalist and half as a primary care physician. She also founded the Gallup Indian Health Services Transgender Clinic in 2013, which provides primary care, hormone therapy, and peer support for transgender patients. She received her undergraduate medical degree and Master's of Public Health at Harvard University and completed internal medicine residency and chief residency at the University of California, San Francisco, where she is an assistant clinical professor as well. She is board certified in internal medicine and addiction medicine. So if you would help me in welcoming Dr. Wei to give a presentation, we'd appreciate it. Thank you very much. You can use your visual hands or claps, but we're very happy for this presentation. Dr. Wei.
Oh, thank you so much, Elton. I am incredibly honored to be here. I have already learned so much from Itai. Thank you so much for that wonderful presentation and sharing your beautiful stories. And I'm so excited to be presenting with Cathy and with Mattee. I will say Mattee is also my teacher. I am sure I will learn an incredible amount from Cathy as well. So thank you for allowing me to be a part of this conversation and for allowing me to talk about something that is not COVID related for once in the last 10 months. So I appreciate that. As Elton mentioned, I did my medical training in San Francisco, where I was very lucky to be able to get additional training in transgender healthcare. I worked in a primary care clinic that provided hormone therapy for folks, and I worked there for about 3 years. before coming out to Gallup, New Mexico. And when I came out to Gallup, Dr. Irulu, I'm going to shout him out as well. He's also been an incredible mentor of mine. He's one of the HIV doctors who's been out here for over 20 years in Gallup area. And he had seen that I had worked with transgender patients in the past and said, hey, you know, we on the Navajo Reservation don't have a transgender clinic, and talked about a lot of patients who he had been taking care of in his clinics over the years, saying many people were accessing hormones online, off the streets, unsupervised, and it seemed like many people didn't feel safe to come to access care here. And so with the help of an incredibly supportive staff, we were able to start the clinic back in probably about 8 years ago now. And since then, we've had over 120, 130 folks come from all over the reservation, whether they're coming for primary care, whether they're coming for hormone therapy, et cetera. And it's these experiences that I'm so incredibly lucky to be able to have bring these experiences to you guys, and whatever I've learned, try to share with you. Because of course we know that transgender patients don't just seek care in a transgender clinic, but throughout the whole healthcare system, whether it's in the emergency department, getting their labs drawn, getting a COVID vaccine, hopefully. And so I'm just so appreciative of this venue and the opportunity to share some things I've learned, and also to open up the discussion to hear about your experiences, as I know there's a lot of expertise on this call. So just want to talk a little bit briefly about the difference between sex and gender, the range of sex, gender, gender expression, and sexuality. Touch a little bit on the medical management for people with gender dysphoria, and I'll talk about that term and how it is a bit controversial. And then understand the barriers to care for transgender patients, and discuss ways to make our clinics more trans-friendly, the latter two of which I really hope to get more guidance from the panelists as well as a lot of the people on this call. So I think when we think about what it means to be a man and what it means to be a woman, a lot of things come to mind, whether it's anatomy, whether it's gender expression, whether it's our roles in society, how we dress, how we identify. And I think it's, you know, I remember putting this slide up before, the sex gender model, and it's really important to think about being a man and being a woman is not one binary thing. It is actually composed of so many different things. Hair color, eye color, and an individual person embodies so many different characteristics. And so I think it's important. This framework has helped me understand a little bit about how people present. And so, for example, it's not just that you're a man or a woman, but every single person has a biological sex, which is the hormones, the primary sexual characteristics, which are the genitalia that you're born with, and then the secondary sex characteristics that we often think about that hormones dictate at puberty. So that's biological sex. Everybody has a gender identity, how they identify, whether it's identifying as a man, identifying as a woman, identifying as gender non-binary, et cetera. And then everyone has their own gender expression. And that varies, of course, based on culture, based on time, based on setting, whether it's the way you dress, the posture, your roles in society, and then who you're attracted to. So I remember when I first put this up, I said that this was the traditional sex gender model of having it be so binary. And very, very importantly, I was corrected by saying, what do you mean by traditional sex gender model? Because this is not my tradition. And so that was really important for me to understand. So I've renamed this the binary sex gender model, where if your biological sex is male and you have XY chromosomes and you have more testosterone and testicles, that you would identify as a man and you would express yourself more masculinely, whatever that means in your society at that point in time, and that you'd be attracted to women. And then, of course, the converse for females. But what we know is that this model is so problematic and incorrect, right? That not only do we know that there are not just binary models of biological sex, there is a category called intersex, which actually 1 in 100 people fall under. Some people don't have XY or XX chromosomes. Some people have XX, XO, XYY. And some people, even if they have XY and XX chromosomes, they have other changes in their hormones that do not fit into these neat boxes of male and female sex. For example, there's someone who may have androgen insensitivity, meaning that they might be born XX, might have XX chromosomes, but that, XY chromosomes, so that they would have a lot of testosterone in their body, but their body cannot sense the testosterone. So when they're born, they may actually be born with what looks more like female genitalia. So all in all, the breakdown for biological sex, we see that there actually is a spectrum for biological sex. It's not binary. We know that biological sex is not inextricably linked with gender identity either. We know that just because someone is XY doesn't mean that they would identify as a man. We know that just because someone has biologically male genitalia, that doesn't mean that they're going to identify as a man. And what we are learning more and more is that there is a biological basis for gender identity, and as well as a genetic basis based on fraternal and identical twin studies that tell us that it doesn't matter necessarily what your chromosomes are, what your genitalia is, that you could still identify across the spectrum, regardless of that. We think gender identity is polygenetic, as well as multiple genes that are involved, as well as environmental factors. And then of course, we know that there is a spectrum of gender expression, et cetera. So let me just remove this very problematic and incorrect sex gender model and throw up what I would like to say is revolutionary, or just like the correct sex gender model, which I can't even put in all of the other words to make sure that I catch every single way that someone may identify. But this is just an example of how biological sex, there's a spectrum. Gender identity, there's a spectrum. Gender expression, there is a spectrum of all of these characteristics of an individual person. So again, emphasizing we are not just man and woman, we are human with many different characteristics, all of which can be along any of this part of the spectrum. And then not just arrows straight down, but arrows all over the place. And that these can all be ways. And so I will say it's been really, really great to be able to explore this model with some of my patients who are coming in and are still not quite sure how they identify. They may feel like they want to express themselves, a biological male may feel like they want to express themselves more femininely, but really still does identify as a man, you know? So understanding that each one of us have all of these 4 characteristics, and of course, millions more, but helping people understand where they might identify based on this model. So I'd be very curious to see how the other panelists and other people on the call feel about this. If everyone agrees, let's just say that this is the correct sex gender model, and let's send it to the president. Okay. Cathy, I'm getting a clap. Good. Okay. Unfortunately, we know many of these people that don't fit into that nice, neat vertical line all the way down the ends. Many of these people are discriminated against, you know, people who are intersex, people who are transgender, people who are gender nonconforming, although the new term really should be gender diverse, because gender nonconforming has a little bit of a judgment there of what does it mean to be conforming. And then homosexual, bisexual. What we know, and unfortunately this has continued throughout many, many transgender surveys, is that transgender people are discriminated against to a far greater degree even than any of the other sexual and gender minorities. 30% report being fired, and this was actually from 2015, from the survey of 2015. Please update me if there's some more updated data. So 30% reported being fired or denied a promotion, 77% were bullied in school, 58% experienced some form of verbal, physical, or sexual harassment by police, and 40% have reported attempting suicide. I wish I could say that from the 2011 to the 2015 survey, there were improvements in some of these numbers. The only one that has improved a little bit is the workplace discrimination, which we feel like has been improved by workplace discrimination policies. But unfortunately, many of these are the exact same. And in fact, the people who have reported being physically, verbally, or sexually harassed by police has gone up. So I think it's, you know, when I'm talking to groups, even high school students, I ask about why it is that transgender people are discriminated against to such a significant degree. And I just want us to pause for a moment and think about that as if we don't think about that every day, as I start to talk about what the medical community defines as someone who is transgender. So let's keep these numbers in mind. So the DSM-5 is the Diagnostic and Statistic Manual of Mental Disorders. That is problematic in and of itself, that that this term is under the Diagnostic and Statistic Manual of Mental Disorders. The fifth edition was put out in 2013, and they changed gender identity disorder to gender dysphoria in the hopes that taking the term disorder away from it would help to decrease the stigma that could be affiliated with something in the Manual of Mental Disorders. It's controversial because the fact that there is something that is in a clinical diagnosis, should we say, that I can put in my electronic health record means that I can bill for my services, means that people can get their hormone therapy included under their clinical care. It means their labs are covered, their other types of treatments are covered. So that is important, and we don't want to lose that, those services, but we also shouldn't use the fact that it's in the DSM-5 as a reason for discrimination, of course. So what is the definition of gender dysphoria? So the definition, these are four main definitions, and I will say the first three essentially define somebody who is transgender, or who has a gender that is different than what was assigned sex at birth. So a strong and persistent desire to be treated as the other gender, manifested by symptoms such as the desire to be and be treated as the other sex, frequent passing as the other sex, the conviction that he or she has the typical feelings and reactions of the other sex, and persistent discomfort with his or her sex or sense of inappropriateness in the gender role. Now, this last part, I feel like the first three essentially define somebody who is transgender or gender non-binary. But what makes it gender dysphoria is this last bullet point, that the disturbance causes clinically significant distress or impairment in social, occupational, or other important areas of functioning. And that's really what, of course, is what we're trying to help people with. But it's so interesting that this is the criteria for an individual person's dysphoria and issue, because if we look back at the number, at the majority of people who are transgender have been bullied in school, have been denied a promotion, have had verbal, physical, sexual assault. How could that not cause dysfunction in your life? And so it really makes you start to think, is gender dysphoria really a problem that an individual person has, that an individual person needs to change? Or is this a problem with the whole world and the rest of society treating a minority group and discriminating against them? And perhaps the world needs to change in order to improve gender dysphoria. I just want to put this up there, and I think this panel is a representation of this. I recognize that when talking about gender dysphoria, it is it's very pathologic. It's a lot of negative about being transgender, and I really, really want to emphasize, of course, as you'll hear from, that many people live very happy, healthy lives, sometimes because of, and sometimes in spite of the reactions of others and the treatment by others. I am a cisgender person, and of course, we all have the ability to be able to, have our own personal, religious, cultural beliefs about people who don't fit in those nice, neat binary categories. We as healthcare professionals also have an obligation to take care of people the best way possible that we can. And I think we have the opportunity to make a really positive impact and the power to make a really negative impact. Again, this is actually probably taught to me more by folks like Mattee, but that Two-Spirit is documented in over 130 North American tribes in every region. And what I've also been taught is that in the Navajo creation story, people who are transgender were very highly respected, even raised to deity status because they can embody both male and female characteristics. And it made me think back again then to our current society and the way we define gender dysphoria, that in times of Navajo creation story, there would be no such thing as gender dysphoria because there wouldn't be any discrimination in social, occupational, other important areas of functioning for folks who are transgender. So unfortunately, we live in a time where there is a lot of discrimination, where people do face a lot of gender dysphoria. in their lives. And so what are the treatment options? Barring our ability to go back to Navajo creation story times, we are living where we are living right now. And so how can we help the best way possible? There's mental health counseling options, phenotypic interventions, phenotypic meaning physical changes to your body, and then of course legal transitions to the desired gender. So what's listed on your birth certificate, what's listed on all your legal documents, etc. In terms of mental health counseling, I will specifically talk about children and adolescents as well. We know that many children and adolescents explore gender expression. It is a very common part of development. The challenge is it's hard to know which of these children that experience that display gender expressions along the spectrum. It's hard to know which of those children and in adolescence will go on to develop more consistent, persistent, and insistent gender dysphoria or difference in gender identity. And the trick is for us to try to catch them as early as possible, because as they're allowed to go through puberty and start to notice changes to their body, that's when they're going to face more dysphoria, more challenges with comorbid mental health issues, other hurtful thoughts. So that is really, really tricky, and hats off to any of our pediatricians who specialize in this, because it takes a whole village to care for children and their families who are exploring this, So I will say these are some of the main types of mental health counseling that we offer. And I will say the one that is advocated for by the American Academy of Pediatrics, by the American Psychological Association, is the affirming mental health counseling. The other three, I will say, are hurtful, harmful, and probably even should be illegal for many of these. So the affirming type of mental health counseling is to allow the child, adolescents, and allow people to explore all of their different gender expressions and not limit them to one or the other. The affirming mental health counseling also understands that people may not fit in this binary of male and female. Wait and see is a little bit more of let's let Tommy and Barbara, let's let them kind of explore which gender expression they're most comfortable with, but ultimately feel like there should be one binary choice that they make in the end. Redirection and reparative and conversion therapy, I will definitely say, is outright dangerous. It tries to provide sort of positive or negative reinforcement to try to encourage people to only display certain gender expressions. And I think, as you'll see in many parts of the country now, reparative and conversion therapy has been deemed illegal. Now, phenotypic interventions, as I mentioned, are physical changes to the body. And especially in children and adolescents, we want to start with reversible things first, and then progress on to partially reversible, and then finally irreversible things, which we usually reserve for adulthood. So reversible things like social transitioning, especially for children and adolescents, allowing them to explore their gender expression, whether it's using a different name, changing their clothes, changing their hair, whatever it means that they are more comfortable with. And of course, making sure that it's in a setting that's safe for them, whether it's just allowing, just having this happen in the family because it may not be safe in the school environment yet, or whatever it happens to be, to allow the child, adolescent, the person along with their family unit, whatever that means, to start to explore some of the various gender expressions. And then also reversible, completely reversible, is pubertal suppression. It's called a GnRH agonist, which essentially is a medication that suppresses puberty, that suppresses the burst of testosterone and estrogen that happens for biological males and biological females, respectively, at puberty. And the thought with that is suppressing puberty to allow more time for the adolescent to continue to explore their gender identity before puberty happens, which again can cause significantly more challenges and struggles. And then partially reversible hormone therapy, I will say, is probably the majority of what I do as an adult doctor, although I work very closely with our pediatricians here on pubertal suppression. So partially reversible is when we start to provide testosterone for transmasculine people who want to see more masculinizing physical changes, and providing estrogen for transfeminine people who want to see more feminine biological changes. And I'm going to go into that in just a little bit more detail in a moment. And then finally, irreversible changes are, although, you know, it is possible to reverse surgery as well, which we've heard a few cases on. But usually we try to have reserve surgical interventions for adults who have been living in their desired gender at least for a year and have been on hormone therapy if it's indicated, et cetera. And usually every surgeon is different, but usually they do require just a little note from whether it's your primary care doctor, someone who's providing your hormone therapy, your mental health counselor, et cetera, to say that they believe that this will really help you with your gender dysphoria. So let me just talk a little bit about cross-sex hormone therapy. This is those neat boxes of biological sex, and what happens, what we see for biological males and biological females. Again, as we know, this does not incorporate the whole spectrum of people who are intersex. But essentially, what we know is that for biological XY, a lot of these secondary sex characteristics that often society views as what is masculine are changes that happen at puberty with more testosterone. So testosterone starting around puberty then starts to be released and causes facial hair, body hair, deepening of the voice, increased muscle mass, etc. And of course, for biological females, during puberty, more estrogen is released, and that is what causes breast development, you know, changes in fat distribution, menstrual cycle, etc. So the goal of hormone therapy is essentially to provide the hormones that allow these secondary sexual characteristic changes, essentially going through puberty again, so that the external, the physical changes in the body align more with how people feel on the inside and reaffirm their sense of gender identity on the inside. And what's amazing is the efficacy of hormone therapy is undisputed. This is not to say that everyone needs to be on hormone therapy, but this was a systematic review of people, over 28 studies with over 1,800 people with, at this point it was called gender identity disorder, because it was, I think, before 2013, yeah, but gender dysphoria, people who are transgender. 80% of individuals reported significant improvement in their gender dysphoria. 78% reported significant improvement in psychological symptoms. 80% reported significant improvement in quality of life, and 72% improvement in sexual function. As an internal medicine doctor who takes care of the spectrum of primary care, I don't know of any medication or therapy that I'm able to provide that makes people this happy. So it's extremely rewarding. And I will say that I feel incredibly lucky to have been able to get the training that I've gotten in various big cities across the country, and to bring them to Gallup, New Mexico, to the Navajo Reservation, to an area that is so in need and so appreciative of these services. It's truly one of the most rewarding things that I've been able to do. And I, again, just thank the whole community for being so willing to allow our clinic here to help in any way possible. Just a couple slides on male to female or transfeminine hormone therapy. Again, as we're trying to do, provide estrogen that provides all of these effects on the left side, essentially thinking what happens when biological females go through puberty. We think a lot of these things are the desirable effects of estrogen, but sometimes people may not be happy that it causes less frequent, less firm erections, decreased fertility, etc. So it's important for when I'm counseling patients to let them know that we wish we could pick and choose which one of these happens, but it's important to know that all of these may happen. Some of the things that we also caution on are the increased risk of various things that are just associated with estrogen in the body. There are certain formulations of estrogen that increase the risk of blood clots. And thankfully, we don't use those anymore, where that's ethinyl estradiol is essentially should not be used for this indication. We do know that people who smoke cigarettes do have an increased risk of blood clots. So this is an incredible opportunity to talk about some of these lifestyle risk factors as well, because we know that estrogen can affect the liver. This is a great opportunity to talk about alcohol cessation, to talk about nicotine and cigarette smoking cessation. And many people are so motivated to make sure that they are healthy in taking their estrogen that we have been able to make a lot of great positive strides in other areas of their life as well. And of course, we also know that as people feel more comfortable and more confident in their body, their incidence of other comorbid things like depression, anxiety, et cetera, also decrease. We also make sure we check their cholesterol levels regularly. We check their blood pressure regularly. We monitor for their prolactin levels, which is also something that estrogen can promote. And so it's just important for people who are on estrogen therapy to have regular monitoring, which of course requires that there are clinics that provide hormone therapy, which of course requires that there are providers that trans folks feel safe in coming to. So there's always a question about increased risk of breast cancer. What I will say the data shows is that estrogen increases the risk of breast cancer to that of biological females. So biological females have higher risk of breast cancer than biological males, but it does not increase it beyond that. And so just as any other woman, it's important to make sure that they get regular breast cancer screening. The forms of estrogen, predominantly we start with the oral pill. It's just a once a day pill that's easier on, easier off. And so we like to start with that. In the occasional side effects where we might see that people's liver tests look a little bit abnormal or their levels of cholesterol have really increased on estrogen, the pill, we will consider the patch. The patch is really probably the safest form of estrogen because it avoids the first pass metabolism. When you take a pill by mouth, it has to go be processed through the liver. A patch does not require that, which is nice, especially for people who have any of these increased risks. We try to encourage the patch use. But generally speaking, the pill is very safe for most people. And the patch is a little bit hard to keep on because you have to keep it on for every few days before you switch it out. And that's really hard to keep a patch on when we're sweating and we're showering, et cetera. And then finally, the injection is also a possibility. I have seen a lot more variation in hormone levels with the estrogen injections because it's injected every 2 weeks, but that also is an option that we can talk about with folks. The other thing that's important for trans feminine therapy is actually to try to suppress the testosterone. For many people, the testosterone can be a really very dominant hormone. And so we try to suppress the testosterone because that really can decrease facial hair, decrease body hair, cause some mild breast growth, and really allow us to not need as high levels of estrogen. And so kind of balancing the testosterone suppression with the estrogen to make sure that the side effect profile is as safe as possible. Really, spironolactone is first line. I don't really go with any other testosterone blocker just because the risks probably outweigh the benefits of any of those. So if people can't tolerate spironolactone, I usually just kind of set it aside and stick with just estrogen. And of course, we have surgical options, breast implants, vaginoplasty, which is creating a vagina, orchiectomy, which is removing the testicles. Orchiectomy is helpful because it does remove the testicles, which is what produces testosterone. So if people have had an orchiectomy, we're able to really, of course, stop the testosterone blocker medication, and we can oftentimes decrease the estrogen levels, almost even decrease the estrogen pill dosing, even up to half the dose that people are currently taking. I wish I could say that the Indian Health Service has plastic surgeons that have expertise in this that we can refer to, at least in my area, in the Four Corners region, and I would again love to hear from anybody else on this call. We don't have any plastic surgeons that are able to do these procedures, and so oftentimes it does mean to see whether their private insurance will cover it, or to see whether they will pay out of pocket for some of these. That being said, we do have general surgeons that can help with orchiectomies, for example. It's not just something that plastic surgeons do, it's also something that general surgeons do for a lot of other indications. So we've been able to work with them to help us with this if people are interested. Moving on to female to male or transmasculine hormone therapy. Of course, you can imagine this is essentially giving testosterone to try to see some of the changes that we see here with biological males at puberty. A lot of what you might expect, decreased voice, increased facial hair, body hair, etc. There also are some things that we caution folks on regarding fertility, that it may decrease your ability to get somebody pregnant. Same thing with estrogen. It may decrease your ability to get pregnant. And then it does increase acne. It can sometimes cause shifts in lipid profiles that can increase the risk of cardiovascular disease. Similar to what we know, biological males can have an increased risk of cardiovascular disease compared to biological females. And then similarly, liver dysfunction. So again, another great opportunity to talk about decreasing alcohol use, decreasing tobacco use, to try to improve and make it as safe as possible to take testosterone. There are various schools of thought. I will say I personally don't think of anything as an absolute contraindication to prescribe hormone therapy. It really is a conversation with the patient each time. Every individual has their own set of family history, set of personal medical history. And there have been times where we've talked to some folks who have had a history of high triglyceride levels or a history of liver disease, et cetera. And they have told me, they have said, I understand my risk of continuing the hormone therapy. I would rather die than continue to live without my hormone therapy. So that's really important to weigh that risk with some of the risks that it may increase the liver abnormalities, may increase other blood clotting factors, et cetera. So I am in that school of thought that it's important to talk to the individual person about their risks and make sure that they understand the risks and the benefits, and try to make a good decision with them together. The main forms of testosterone are an intramuscular injection, usually every 1 to 2 weeks. Occasionally for people who are absolutely not interested in injections, very scared of needles, we have talked about, we do prescribe the transdermal patch or the gel as well, are other options. And as you can imagine, all different types of surgical options are available as well. Removing of the breasts, which we call mastectomy, removal of the uterus, which we call hysterectomy, self-pingectomy, which is removal of the fallopian tubes, or the ovaries, oophorectomy, and then phalloplasty, construction of a penis. Again, we don't have plastic surgeons that are experts in the IHS with phalloplasty. It's a really very, very specialized type of surgery. And one of the things that I've tried to do, especially with being in the Four Corners region, is try to gather as much data as possible from all of my patients about who they found to have, where they found trans-friendly surgeons that have been able to work with them to really make sure that I'm referring and I've vetted these surgeons. So we have folks in Albuquerque and Phoenix area and Colorado area. So try to create a list for just be a repository of that to give out that for patients that are interested in exploring some of these options. So I'm just going to throw this up again as a reminder of what we're going to be sending to the president later. And then tell me how much time I have, because I think a lot of these things will be otherwise covered by the rest of you guys. Just some barriers to care. We're not surprised that many people don't seek care because they feel like they haven't been able to find a trans-friendly provider. They've had negative experiences in the past. The intake forms are very isolating. The office environment is very isolating. And so many people have used hormones unsupervised. I'm just going to throw this up there as things that I've learned from my patients about how we can improve the therapeutic alliance with trans patients, essentially using their correct name, using their correct gender pronouns. And then perhaps the biggest thing I've learned is that if I've used the wrong pronoun or the wrong name, an apology can really be healing, especially for someone that may have never found a provider that would be willing to even use their correct name and pronouns. I'm just going to throw these up there. How can we improve services, offer unisex bathrooms, display office policies that prohibit discrimination, train all staff, not just staff in the transgender clinic, of course, because they're going to be going to the lab, they're going to be going to the ED, they're going to be going to urgent care, radiology, et cetera, and then making intake forms as trans-friendly as possible. I'm just going to throw this up there. A couple years ago, our EHR system is archaic and is not able to incorporate all of the possible gender pronouns, gender identities that are out there. So we, at the very least, and we're working on this, we are working on this. At the very least, what we tried to do is put a transgender flag in EHR. So I remember when I was presenting this to our medical executive committee, they were confused. They're like, the transgender flag, I think they were thinking this. But what I meant was putting a little pop-up in the electronic health record whenever somebody comes in. So if it's, demo patient Mike, actually whose correct name is Michelle, and correct pronouns are she, her, hers, this pops up the second anybody clicks on this chart number, so that that's what we've been able to come up with in the interim until we can make some more and better changes to our electronic health system, which I know actually many people even on this call are working on. So thank you for all your work with that. And I'm just going to end with that, and we'll be sticking around to answer any questions, but just helping us understand the range of sex, gender identity, gender expression, expanding access to primary care and hormone therapy, understanding that we as providers have an incredibly powerful impact on people's experiences. And let's continue the conversation about how do we make our organizations more trans-friendly. Just some of my other information in case people are interested in referring. Thank you so much.
Good, thank you, Dr. Wei. That was a lot of information, but very, very useful and resourceful, and I think from a clinical perspective, it's very important that we're able to kind of view that and hear that. So thank you for presenting that. We have a number of questions that were in the question and answer session. So if you get a chance, or we can ask them at the end, that would be fine too. Some of them are a little bit more clinical. So feel free, to look at those questions. But we'll continue this webinar from some individuals who agreed to give their personal testaments, their personal stories about access to trans healthcare, particularly, with their transitions or just general health as well. So our next panelist is Mattee Jim, and Mattee is Navajo Dene, and she has been active in the HIV prevention field and transgender advocacy for the past 20 years on a state, local, and national level. Mattee is currently employed with the First Nations Community HealthSource as a supervisor for HIV prevention programs, and she's also a decision-making member and community co-chair for the New Mexico Community Planning and Action Group, which addresses HIV prevention in the state of New Mexico. She's also a board emeritus for the Transgender Resource Center of New Mexico and has held other key positions with national agencies and organizations throughout the country. Mattee's journey has been a blessed one since she started her sobriety several years ago. So we're very excited to have Miss Mattee Jim, give a testament and any other information that you'd like to also talk about, Mattee.
Thank you, Elton. So I know time's an issue here, so I'm gonna try to go as fast as possible, but I wanna thank Itai and Dr. Wei for the information that they gave. So this whole webinar is based on what they presented on, and then also looking at access and navigation for care. So for me personally, on my personal journey, I agree with what Itai mentioned about first coming out. I identified as gay because I didn't identify with transsexual, and knowing that I wasn't going to get surgery. And I remember at age 14, I read the definition about transsexual, and I'm like, I think surgery would be too evasive, so I don't think I'm going to do that. So when I first came out, I was gay and really didn't hear the word transgender until the late 1990s. after I had gotten sober and started trans advocacy on the state level here in New Mexico. So ever since then, when I heard about transgender, I identified as that. So that's where the advocacy journey started. So looking at healthcare also, I think was a big part of that too, because when I was younger, there was hardly any healthcare services for trans populations in our area in Gallup, where Dr. Wei works at. My first experience with healthcare was mental health services. When I got sober, I worked with Dr. Lagatuda, who was a psychologist, and knowing that he did work with a lot of youth who were LGBTQ in schools, I think opened that gate for me to really like work with my mental health service, and from there continue on a journey doing advocacy, especially for trans populations. So for myself personally, mental health was one of the things that I had to work on in order to work on my identity, because I did have those statistical barriers that we talked about, those statistics that were mentioned, like contemplation of suicide or substance use and abuse, looking at that and how I coped with who I was, and also acceptance was a part of that. And I think a lot of that is mentioned in a survey that Dr. Wei had mentioned with the US Trans Survey in 2015. And I believe that they are going to be rolling out another one. So I think people who hear about it should try to fill out that information. And the US Trans Survey from 2015 had over 27,000 participants fill out the survey. They also had subcategories with like American Indian, Alaska Native populations. And one of the things that really stuck out, especially with healthcare, was this portion of 1/2, which is 50% of respondents who saw a healthcare provider in the past year reported having at least one negative experience related to being transgender, compared to 33% in the US Trans Survey sample overall. So this is just specifically for Native trans populations. So you see a big number of seeking healthcare and having a negative and bad experience. And I think for me, having to deal with that on a personal level when I was living in Gallup, and having to seek healthcare. And I'm very, very happy that Dr. Wei is providing healthcare for trans populations in Gallup. And I know it's very effective because the girls do talk, the friends that I know do talk, and they're very happy with the services that they're getting and what's being provided. So I feel that it's working. And also knowing that somebody drives 5 hours just to get seen by you at the clinic tells you something. Or sometimes some of the challenges could be transportation, especially for a trans person who has to hitchhike to get healthcare services. So those are some of the things that I wanted the participants to maybe think about, because sometimes those could be a hindrance in accessing healthcare. So we're looking at different ways on how we could provide better healthcare, access to healthcare, and how do we navigate that system. So I'm really happy to be a part of committees and groups now that are addressing these issues. There's two that I'm not sure if Itai mentioned, the trans affirming healthcare echo that we do with clinicians, and talking about healthcare for trans populations and individuals, and doing that peer-to-peer support, giving resources, information to people who are providing care in the Indian health service sector. And then also being a part of the Native advocacy work group for trans health, and actually looking at implementing or coming up with policies and procedures for healthcare in IHS, urban health clinics, 638s, and different Native health organizations. So things are moving. I can say the navigation is coming, the access to care is coming, and we're working on it. There are people who are committed to making it better for our Native populations, especially in Indian country, on the reservation. So I'm really happy to bring that up also too. And I really like the way that Dr. Wei kind of mentioned, like the mental health portion, the physical portion, and documentation, because that's what I wrote down on my notes of what I was going to talk about, especially with my personal experience. And accessing hormone therapy. And for me, the first time I accessed hormone therapy was actually in Los Angeles, which was the BART clinic. And that's when I used to work for Elton in Los Angeles, that AIDS Project Los Angeles and stuff too. So I was very fortunate to have started hormones there. And then also having to come back to Albuquerque, work here, and get transferred into Indian Health Services, and knowing it was a smooth transition to continue my hormone therapy. So to this day, I'm still accessing those services, and I'm still getting my hormones, and they're in the pharmacy formulary that provides that for me free of charge. So I'm kind of happy with that. So looking at that also. And one of the things that we really don't discuss sometimes is the actual documentation, because documentation plays a big part in what we're talking about, access and navigation too, because that's important. And I think as service providers or people in different states or around the country, looking at how your documentation is done and how it could be changed in your city, in your county, or even in your state, because some may be easier than others. I'm fortunate to live in New Mexico, where you can change your driver's license gender status easily. Before, a doctor had to sign a form for you and you turn that in, but now you actually fill out the form yourself. You go to a notary public and then turn that form in, no questions asked. And then also the birth certificate law that was passed this past October also was actually 2 years ago in October, a year in October, where you just fill out a form and you can change your gender marker on your birth certificate also too. So for me, as a Native trans woman, I was able to do that easily, and I was fortunate to do that. So really knowing like your documentation process or paperwork process on the state level, and also within tribal communities, because tribal communities can do that too, and some could be easier than others. So it's really good to look into that also too. So that's a part of that access and navigation that we talk about. And I'm really glad that we talked about some of the healthcare that's being done within our communities. And for me, I'm so happy. I'm always bragging about Dr. Wade to everybody across the nation too. So, and I also brag about the Northwest Portland Area Indian Health Board and the work that we're doing for trans affirming care and healthcare. So being a part of those two entities, I think is wonderful. And I look forward to the day where Indian Health Services can actually provide gender affirming surgeries to our population. And I'm looking forward to that. So I think that's where the access and navigation goal for me, I look at that as something that I want to accomplish or to see fruitful for us to get surgeries. And I think one of the things, one of the challenges that I see within that is that people think that all trans people want surgery, which is not true. There's a handful of trans identified people who do want surgery or do want gender affirming care, but not all. Like for me, I don't want to get surgery. Maybe down the road I might, but for now I'm comfortable. The hormone has done what it's done for me, and I love it. I feel great. I live my life the way I want to live. I'm happy. Like Dr. Wei was mentioning, like it makes you happy, and I am happy in who I am and what I'm doing and living as a trans woman. So that's just a little bit about my testimonial and some of the work that's being done with the services that are being provided and stuff that's being done on the state level and also on the national level. So I know I only had a little bit of time, so I'm going to wrap it up there, and I'm going to turn it over back to Elton to introduce our next presenter. So thank you.
Yes, thank you, Mattee, and thank you for providing all that information in that little bit of time. I know your story can be more of a saga, but we'll let you do that later. But you bring up very important points in terms of transgender services, particularly in Indian Health Services. It's really grown over the years, in terms of being you know, a little bit more competent, but actually, you know, the access to those services. So we, you know, I really, you know, commend a lot of the advocacy that you've done, but also within the Indian Health Services, you know, to be open to providing those medications such as hormones, but also access to clinical care. You know, and then just to let people know, ECHO is a telemedicine virtual portal that Mattee mentioned about, that the Northwest Portland Area Indian Health Board does provide. So if you are a clinician, you can either contact Mattee or Itai about how to access that program, where you can talk with individuals who come from the trans community, other clinicians, on any issues that you may be having, providing the best care that you can for our trans relatives. So thank you for that. And then our, not our final presenter, but our most esteemed presenter that we have on this panel is Ms. Cathy Kapua, who has worked with the transgender community in Hawaii since 2003. First serving off as a peer educator at Kalua na Mamo, then eventually moving on to become the transgender service manager at Hawaii Health and Harm Reduction Center. Cathy has proudly expanded her social justice work as she's now joined the Trans Justice Funding Project in 2020 as their deputy director, and proudly helps to move resources to grassroots trans-led programs throughout the United States and its territory. So please help me in welcoming Ms. Cathy Kapua. Taffy.
Aloha mai kako, Cathy Koinoa. Thank you so much for that beautiful introduction. Thank you, Itai, for sharing about programs and how things are working. And thank you, Dr. Wei, for really explaining my whole life and my whole science behind it. And Mattee Jim, you're always my sister and inspiration. We stand together on so many points and national advisory boards. So thank you for guiding me and inviting me also to this panel. I also wanted to recognize that many of the things that I was about to say, I have written down and have already been said already. So I'm just going to echo some of the things. And when asked to speak on here, I realized that I think the best part for me to start is just to share my story. And really briefly, as I know we have about a couple more minutes. I knew that I was different when I was 5 years old. And I knew this when my mother was raising me Catholic, teaching me how to pray. And in process, I would pray to wake up and be a girl. So I know this was different for me. As I fast forward, I didn't have resources in the 80s and the 90s. So when I turned 19, I realized who I was by meeting somebody just like me. I live on an island, I live in Hawaii, and word of mouth is our way of communication. And I found someone who was similar to me, invited me into a community, which was the club scene, where I met my family. And my family, actually, my chosen family, became the ones who guided me. As we help each other in the community, I learned about hormone therapy. I learned about silicone injections. I learned about medical tourism, so traveling to get surgeries to Thailand or other third world countries for surgeries. And I learned how to survive as a woman through street economics. I would keep it simple and say sex work was a part of my past. Selling promotional drugs was also part of my past, where I paid with my life. At 19 years old, I went into a men's prison. I was there for 4.5 years. And in there, I learned my voice. I learned how to stand up for myself and others like me, as there was other trans and genderqueer people in the prison system that was wrongfully placed and placed in dangerous situations. So another topic that I would love to talk about one day too. Coming home, by learning my voice, I advocated for how our housing was placed in the prison system. And when I was released from prison system, there was a whole slew of community willing to take me in and help me out. And this is my chosen family. I'll say that for the past 17 years, I think me and other trans leaders here in Hawaii have really guided the efforts that have led us to today, where I'll share in a bit. As I've been living as a woman for 24 years now, I have people like Hina Limwana and Ashliana who actually guided us and helped us in the beginning stages of advocacy and changing the laws. We now have other up and coming, new, beautiful, brilliant Indigenous leaders, Kapua Okalani, Kapolio Pele, Kumuawa. We also have Madeline and Bianca and Ciare and Sina, Kiva and Natalie, all doing statewide work at nonprofits and clinics here in Hawaii. But when it comes time to advocating for laws, all of our trans power comes together, and we've been advocating together. I'll summarize it by also saying that we're successful in changing our birth certificate laws. We were successful in changing our health insurance inclusions for trans care in Hawaii. Gender X on gender mark on our driver's license was really important for our genderqueer and non-binary folks. We also banned conversion therapy in Hawaii. And it seems like, wow, you all did great work. But I tell you right now, it took a lot of community, a lot of trans leaders, and a lot of personal testimonies and stories like what I'm sharing too. So I'll also say that if these are providers on the call and are listening to how you can create a trans program or how you can provide best services, my biggest advocacy is to hire trans and genderqueer people within your program. Not at the ending as an afterthought because we need recruitment or you need an outreach person. At the beginning when you're writing the grants, in the beginning when you're actually developing, because their experiences and their stories can actually guide and make or break your program. In Hawaii, everything is word of mouth. So the moment the community hears of misgendering or wrong pronouns or calling people derogatory things, immediately that clinic gets a bad reputation. So I think that's a huge one. Another big advocacy, another point of advocacy I wanted to make is, in my life, I've had a lot of trouble with relationships, whether it be with my partners or other things. So I can actually tell you that because of my gender affirming surgeries and the many that I've had, I can list them all down, and hundreds of thousands of dollars probably came out of pocket or paid through the insurance. It has built me into a powerful person today. So my experiences and my choices and the quality of my life that I make now have definitely surpassed anything that I've imagined. I'm 43 years old now, and I embrace that because I have passed the point to where people told me that I wouldn't live past a certain age. I didn't think I would live past 35. I didn't think I would actually become an elder myself one day. And now I see the choices in front of me because of the medical access I was able to get. It wasn't always that way when I was on the streets or when I was younger before prison. We had access to a doctor who gave us access to black market hormone therapy. We paid $20, we got a shot. You didn't have $20, you didn't get no shot. No documentations, just a picture ID to prove that we're over 14 years old, because he only wanted to give people above the age. We've also I've traveled to Mexico, Guadalajara, and paid a discounted rate for my first pair of breast augmentation, for facial feminization, for jawbone and forehead, and liposuction and stuff. And this process was important to me in my journey. However, I have some scars and some things that are non-reversible, and I have to claim that I have to figure out different ways to navigate it now. I have to figure out other doctors to help me correct some of the things that that happened. And then lastly, I also access illegal silicone injections. And this is the only way in the 80s and 90s here in Hawaii that I was able to access some of the care or to feel comfortable in my body. So silicone injections is illegal in the United States, is not recommended. Now in the 20th century, we have wonderful access. We have BBL. They can remove fat from one area, they can put it in another area to create that illusion that I was always going for. So there's so many different and better ways to do things now. And I'm so glad that we're able to advocate for some of those. And then I know we're running out of time, so I want to make sure we have time for questions. But the last thing I want to say too is the choices that I've made now, I can look back and I can see that even though it seems like I may have access to all these things and all my privileges, and also being on the binary, knowing that I was born male and I wanted to be female, these are all my privileges that I get to walk in life with. It doesn't mean I don't continually need support. as a healthcare provider, I feel like there are things that you should also be able to help guide them through. And some of these things is mental health wellness and making sure that people have access to a therapist or somebody to talk to. I've learned this by experience, and I hope people can learn from me, is my friends don't want to hear my drama. My friends want to celebrate with me and love with me because they also have their own drama. When I have drama, my friends have drama, we talk to each other, we're just piling each other's trauma and making each other a lot more stressed out. So I feel like community has a place, and this family always have spaces for each other, and that's why we're family, but also getting a professional help and getting somebody to be our mental health therapist or somebody to talk to. And then lastly, I want to talk about is sexual and domestic violence. Sometimes that plays a big part. In my younger years and growing up, I didn't know who loved me, and I accepted love in different ways and different forms. And now that I'm 43 years old, I have my vaginoplasty, labiaplasty, breast augmentation, facial feminization, chin, jaw, my name changed, my gender marker changed. I have a great job and I have stable housing. Now, with the quality of life that I have now, I make different decisions on who my relationships are with. I make different decisions on who I can love and who I accept in as family. And I feel like these are my privileges that I wish for everyone. I wish that everyone has some sort of support and receives love, however it is. You saw me earlier holding my doggies, and my doggies is my love. And that's mental health wellness too. Finding that way of how you can heal from all your past traumas is really important. The medical stuff is just as important. And I feel like my transition took a whole journey, and it took 24 years, I have to count numbers, 24 years before me to get to this space where I'm happy and comfortable and happy in my life. So I appreciate all of you for listening to my story. I could talk more. I want to make sure we get to these important questions. So thank you all for having me. Aloha. Thank you, my Hawaii people. I see you.
Well, mahalo,
Elton?
Cathy. Thank you for that abridged version of your story. You've really come full circle, if you will, and your happiness is just exuded, in your story. So thank you for allowing yourself to share that with us. So in terms of questions and answers, Dr. Wei answered a majority of the questions in the chat box. There is one open question here that I will open up to the panel, which is, hi there. What are your thoughts on weekly estradiol injections and use of bicalutamide, I'm butchering that term, over Spiro? So Dr. Wei, maybe you might want to pronounce it right first and then answer the question.
Oh, sure. I'm actually just in the process of finishing typing it. Yeah, so typically estradiol injections are recommended every 2 weeks. But I sometimes will recommend trying weekly injections if it seems like we're having too high peaks of estrogen, if we're noting some other side effects. Sorry, there's people just next door, but I should be okay taking this off. And so sometimes using the same dose, so let's say you're taking 20 milligrams every 2 weeks, taking that same dose and dividing it in two, so 10 milligrams every week, is something that sometimes we'll try to see if it'll decrease those peaks in estrogen, which may be what's causing, say, the abnormal cholesterol levels or increasing the risk of blood clots that we don't want to see. And then the bicalutamide is a type of testosterone blocker, which some people do use to block testosterone, similarly to how I use spironolactone. It's a little bit weaker of a testosterone blocker, and so we sometimes feel like the risks of that medication compared to like the possible mild benefit of testosterone blocking may not be worth it. So that's why I've tended to stick with spironolactone, but it's not wrong to try and see if that helps to suppress the testosterone levels. I usually will check people's estrogen and testosterone levels to try to make sure that they're at the levels of the desired sex. That being said, there are people who are gender non-binary that may not want the levels of testosterone, say, that of a biological male. And so we will just give a little bit of testosterone or a little bit of estrogen and just kind of help to work with each individual person's goals.
Okay, great. And thank you for explaining that. you know, it's a lot to take in, but it's very well explained in the way that you were able to do. So thank you. You know, our time is at an hour and a half, but I just want to give everyone on our panel a very big thank you. I think it's a diverse panel. We may have to do a follow-up webinar for this particular topic and for our trans relatives, just because there's so much to take in and understand. But I think the main content and point of us being able to have this webinar is to, you know, to begin to have those conversations, to learn a little bit more, you know, to make those connections between our clinicians, you know, and our trans relatives, you know, and to know what, you know, our trans relatives are experiencing, you know, and we want to be able to get all our relatives to that happy place, you know, to that balance, to that beauty, as we say in Navajo, that hajo, you know, where we can support our relatives in that way. So thank you for sharing your stories. Thank you for sharing the information and the work that you all continue to do. I believe Cathy put her information there, as well as Itai. You know, we'll make the PowerPoint available on the NNHN website, as well as our YouTube page, so you can share this presentation to others. You know, any last words from our panelists that we may not have covered fairly quickly?
I just want to say thank you, Elton, for being the moderator and making this run smoothly. So thank you.
You are welcome. Thank you. And thank you all. You know, stay safe, wear your mask. We're still going through a pandemic. You know, so let's continue to play our part in keeping our community safe. And again, to the panelists, thank you for agreeing to, you know, present on this webinar. I think we had some fantastic people, you know, present. And as I mentioned, we may do a follow-up webinar on this topic, or more specifically on any other topics related to the trans community for our Indigenous Native relatives as well. So thank you. We do have another series, another webinar we'll be doing as a part of this series in February, and that will be on HIV and our Native elders. So we will get that information out to everyone. And then in March, we will have a series of activities recognizing the National Native HIV/AIDS Awareness Day. So feel free to keep in connection with us. We do have a website. We do have our social media platforms. So feel free to join those and stay updated with our communities. Okay. Thank you very much. Have a great rest of the day.